Good afternoon, and thank you for joining today's webinar. I am Lori Smetanka, the Executive Director of the Consumer Voice. Today's webinar is the third in our series on improving the nursing home closure process for nursing home residents. We're delighted to share with you today the experience of representatives from 2 states that have been working with our project team over the past year on the issue of nursing home closure. This important project has been supported by a generous grant from the Retirement Research Foundation, and we thank them for their support. Please note that all of your lines will be muted throughout the webinar. Questions can be written into the question box on your control panel, and we'll get to as many of those as we can at the end of the presentations. And as you just heard, the webinar today is being recorded. So without further ado, I will introduce you to the project's director, Dr. Cynthia Rudder, who will start us off with today's presentations. Cynthia, I'll turn it over to you.
Thank you. Welcome to everybody. This is the third webinar, third and last webinar in a series of 3 that we had. The first one talked about our original study, which also was supported by the Retirement Research Foundation. The second one talked about the federal rules around discharge and closures, and also talked about some of the best practices of our best practice states in the report. And today we're going to hear from 2 other states in our new project, Working with States. As many of you know, the reason we did our study in 2015 to 2016 was we were hearing some of the things about negative impacts of nursing home closures. Lisa, you can just move through these. So in 2015, we decided to do a study to really find out what was happening. And using online surveys and one-on-one interviews, our objective was to identify obstacles to a successful closing for nursing home residents, identify policies and procedures for overcoming the obstacles, identify best practices, and make recommendations. We have the full report on the Consumer Voice website, and many of you were participated in our first webinar where we went over this report in detail. Some of the conclusions to our study, that earlier study, was that there were obstacles to a successful closing. Most people talked about the fact that there were a lack of appropriate and nearby placements. Some of them were appropriate, but facilities did not want to take certain types of residents. Poor discharge planning, lack of communication, poor notice, staffing issues, and transfer trauma. Our state best practice case studies was Ohio, Wisconsin, and Connecticut, and some of you heard some of the representatives from those states talk on our second webinar. And these are some other states with best practices. All of this is on our website for ideas that some other states can use as they try to look at their own nursing home closure process and see whether there are things that they can find that other states have found successful. Our new project, which we're really talking about today, is during the last 10 months, we worked with 2 states as they examined and worked to enhance their nursing home closure process to try to improve the process or enhance the process in some way, and that is Michigan and Tennessee. I just want you to know that they were 2 different types of states, not only being in different geographical areas, but Michigan State Ombudsman Office is independent of the other state agencies. Tennessee is part of the state structure of agencies. We wanted to work with 2 states that had 2 different types of structure. Next, please. The project activities, we gave each state a 1.5-day training summarizing our earlier project with recommendations for Ombudsman and other state agencies. Next one, please. We asked each state to choose 2 recommendations to work on from our earlier study, and we facilitated a discussion as each state developed these goals and actually created a 12-month work plan. What did they want to do? What were the goals for their state? And then we worked out what activities they needed to do or wanted to do to actually achieve it. Next, please. We held monthly or bi-monthly conference calls with each of the full relocation teams of each state, which included some state agencies that were new to the team that had not been an earlier part of the work in those states. The two states that we chose, Michigan and Tennessee, chose to do a number of things. Both of them chose to either improve or enhance their closure team in some way. All of them one of them tried to figure out a way to include the state ombudsman in the closure plan review. And one state also developed a tool to follow up with transferred residents to prevent deterioration and transfer trauma. This project ends at the end of June, so there are 2 months left for the states to work. You're looking at a work in progress on these two states, but you're going to hear some really exciting achievements of these two states. I'd like to turn it over now to the representatives from Michigan, and if you can go to the next webinar, people can see, Alicia, who is going to present. So I'm turning it over now to Sally, Steve, and Lori.
Thank you, Dr. Rudder. This is Sally Pung, the State Ombudsman for Michigan, and the three of us are going to collaborate today and share each of the slides and give you a little feedback on the agenda that we suggested for today. So first of all, we certainly would like to thank the Retirement Research Foundation and Consumer Voice for allowing Michigan to participate in this project. I think one of the biggest benefits for Michigan was that this project gave us a great benefit as it helped Michigan regroup after having years of regulatory closing events, and really helped us focus as a state on what a process should look like for voluntary closures, because it was a little bit new for Michigan to experience. So if we can go on to the next slide, we'll speak specifically about the benefits. First of all, we really had to identify the needed participants. I think it was great for us to come together as a group to identify the persons who should be involved in the closure process. For Michigan, that of course included our state survey agency, our Medicaid agency with long-term care policy staff in management positions and some policy analysts, the OBRA coordinator for our PASSR process in Michigan, the staff that were responsible for nursing facility transition policy, staff from the My Choice, which is our home and community-based waiver program, the operations side, they were involved, and very important, I think, to the project were staff from our adult protective service and adult service workers that really have, for years, have been responsible to assist residents in relocations, and then the Ombudsman program. So we think it's very important to maintain this resource information for contacting responsible individuals and for coordinating or sharing of what information when it's possible. Coming together as this group really allowed us to understand who should be part of the process and the important roles that we all play. I think it was another benefit was to understand agency resources. We were able to identify the available resources within each other's agencies and see through the silos of large state agencies and establish communication that can reduce some barriers. I think that was very helpful, and I know from the Ombudsman perspective, we are now communicating with other agencies on issues outside of just closures. So I think that was a great benefit of being part of this work group. And then, of course, develop a shared vision. I think we all have great ideas about what a relocation should look like, and some of us have a perspective from the resident focus, some of us have more of a provider. So I think it was helpful for us to come together as a group and really discuss about what the shared vision should look for resident relocations and commitment from stakeholders. The work group meetings allowed us an opportunity to share communication platform for the group and discuss issues before and outside of an actual event. Then I'm going to turn it over to Steve to talk about a few more benefits.
Good afternoon. Laura is the state agency in which the Bureau of Community Health Systems resides as the state survey agency. And Laura stands for the Michigan Department of Licensing and Regulatory Affairs. At one point in time, the regulatory activities concerning the state survey agency on behalf of the Centers for Medicare and Medicaid Services, we're actually under the same umbrella as the state Medicaid agency and the state long-term care ombudsman. Due to organizational changes made by the governor, all the licensing and regulatory functions within the state are under LARA, and the policy and financial aspects of Medicaid are under the state Medicaid agency, which is now the Michigan Department of Health and Human Services, not to be confused with the federal Department of Health and Human Services. And what you could see just by that brief explanation of part of the history of the agency that I work within is that we are geared towards ensuring that facilities under either state law, because each nursing home is state licensed, as well as under federal law if the facility is federally certified to provide nursing home services and get reimbursement under Medicare. We have to ensure that state law is being followed, as well as the requirements of CMS through its myriad of federal regulations that are codified based on statutory authority in the Social Security Act. So what you have is really kind of a silo in a way that we operate within, because we have to follow the regulation. We do not go beyond what the regulations enable us to do, and we are not to go below what the regulations require us to do. And I say that because when you look at the Ombudsman's office, it's an advocacy office, so there's a lot more that can be said publicly and to families, as well as the facilities, in terms of trying to enhance services. When we go through our processes, mainly the requirements of CMS, we're monitoring, regulating, following laws and rules, and we act as a surrogate for the Centers for Medicare and Medicaid Services through authority that's in the Social Security Act and a section of the Social Security Act, 1864, that requires us to have an agreement with the federal government so that we're funded to do the work on their behalf. A lot of the federal regulations require confidentiality, and it sometimes conflicts with what other areas are trying to do in terms of planning ahead and making sure that residents are adequately served during a closure. So I will, having given that overview of roles and responsibility, one of the things that we have worked on through this project is a facility closure checklist that each facility will have, and it requires them to provide, going down the checklist, documentation that we are authorized to review or must review before we can approve a closure plan for a facility closure. Within the perspective of this checklist are certainly certain time factors. A facility has to provide at least 60 days prior to closure a closure notice to all residents. So we're going to be looking to see that the facility has gone out and provided such notice. In addition to the closure notice, the provider must also provide a resident-specific discharge or transfer notice at least 30 days prior to the discharge or transfer. So we will be looking that the facility in this checklist has complied with those two requirements. In the second notice, the 30-day notice, the provider must identify all the necessary elements as required by federal regulations for the individual resident, including the location to be discharged to or transferred to, along with a notice of a right to appeal. And that right to appeal, if exercised, will generate an administrative hearing, depending on the circumstances and the basis for discharge or transfer. But what will happen is if an appeal is filed, it will, in essence, stop the 30-day clock from ticking for the individual resident. Once that 30-day period is affected, it can potentially affect the 60-day period as well. So what will happen is that the time frames for closure or actual closure will have to be adjusted based on certain actions that the resident or the resident's guardian or family members may take in appealing the transfer or discharge. So the checklist was a major accomplishment of the work group. The checklist is for Laura's use, but once Laura receives the checklist, it is shared with the Ombudsman as well as the state Medicaid agency, because they also have separate roles and responsibilities in terms of a closure. And I will defer to them to discuss what those roles are and the timeframes as they come back around to provide more information to you. So I'm turning it over to Lori at...
Hi, this is Lori Earhart. I'm with Medicaid. One of the roles that I have in my job is to serve as closure coordinator. So I've been quite busy lately. One of the main benefits that the work group has had for me is that I'm relatively new to this particular role. So this has really helped me to clarify and identify the roles and responsibilities of the different players, if you will. It's also shed a lot of light on the materials that Medicaid needs to develop to help providers. The checklist that Steve referenced, the development of that has been extremely helpful to everyone. And it has also helped Medicaid to define what we need to provide in terms of additional materials. We have a variety of checklists and tools and best practices that provide guidance to providers. However, they have not yet been put together in a way or packaged in a way that is really helpful to facilities, that is easy to access, that they can access and immediately see the value in using those materials. So that's, I guess I'm also rolling this into the challenges and obstacles that we face because we need to figure out how to put together a vast amount of each of information in a way that doesn't intimidate people and put them off from actually utilizing it. I guess if it's okay, we'll continue to speak about obstacles, and I'll turn that back to Steve.
One thing I will mention concerning the checklist is it's the full intent after all of the stakeholders pull their material together to do, in essence, a side-by-side comparison of the different roles and responsibilities to further look at where there may be overlap. You heard me speak to some of the confidentiality provisions that may apply to some degree while a facility is in the process of looking at a closure. But once the process has begun, then there's the possibility of collaborating and sharing information with the other stakeholders. So one of the obstacles that was certainly a concern within Laura and the Bureau of Community and Health Systems is that we can't exceed our regulatory, statutory responsibilities. And so some of this has been kind of like the yin and the yang in terms of everybody knowing something may happen, but not being able to openly discuss it because of the confidentiality provisions. So based on past practices and desires of the state relocation team, which is not in our regulatory agency, we sometimes are in the position of having to kind of push back and say, we can't share that information with you right now. But we've assured the stakeholders and our colleagues in the other agencies that we're going to work with them to provide as much information in a timely manner when we are permitted to disclose that information. The other obstacle that has arisen during closures in the past is that the facilities sometimes get confused because they know who regulates them, but then other entities are showing up at the facility and they get the impression of, you know, who is the lead agency, who has what authority to tell me or to ask questions, to tell me to do something or to ask questions. So it gives kind of the appearance that a group is coming in and taking over the facility or the facility closure. So we, through our process, are ensuring clear information is going out to the facilities in terms of what the roles, responsibilities, and authorities are of the various stakeholders. And nobody, I don't want to give anybody the impression that there is any, attempt to not help the resident. It's just in the sense that it has to be done in a very strict way that the regulations are followed. So at this point, I'm going to turn it back to Sally.
Thanks, Steve. Some of the other obstacles, I think, as a team that we identified was there was a limited history or experience of closures by some of our stakeholder members. Some of us have worked on closures for almost 20 years, and some people came into like Lori, joined our group after it had already started and didn't have quite as much experience. So I think that having that turnover in personnel and lack of updated or accurate documentation about roles and authority was kind of a struggle for our work group, especially I think I could speak for myself, for someone that had so many years of closures and all of that experience. It kind of was interesting to sit at the table and to talk about events that people weren't aware of, or it just put obstacles in the way. And I think that there are times that my experience may have created obstacles from us moving forward to really clearly define roles and limitations within those roles. So it's something to be mindful of if a group comes together, to really get a clear understanding, I think, of how the history or experience or lack of that can be an obstacle for a group. And then I think confusion for providers. you know, when the roles and responsibilities, as Steve kind of alluded to, when a group shows up on site at a facility, when the roles and responsibilities aren't clearly defined, it can be confusing about who, as a provider, do I really report to, or as a resident, who really has the authority to offer me help or see my records, and who do I have to give consent to. I think those are a lot of obstacles that you kind of have to work through this process. There are also multiple channels of communications for the providers from multiple stakeholders, and I think that can be confusing at times, and I think we're still, as a group, working on how to streamline that as much as possible. Just make it simpler for providers to know that they're communicating. You know, a lot of providers see the state as the state. They don't realize there are multiple agencies that all have different responsibilities and different authority. So once they speak with one portion of the state, they feel like they've covered the entire state. So I think through our work group, we're trying to identify where we can break down those barriers and those obstacles and help the provider have much more consistent and clear communication, and you know, help them get a plan in place as soon as possible to move forward with the relocations. So Lori, I'll hand it over to Lori and see if she'd like to add from the Medicaid perspective what obstacles, if you have any.
Thanks, Sally. I want to start out by saying, I guess this isn't an obstacle per se, but even though, as we've discussed previously, each agency does have a somewhat different legal mandate, I just want to emphasize, as Steve did, that we all do share the mandate or goal of ultimately trying to protect vulnerable residents during a potentially really traumatic event. So I just wanted to emphasize that. And Medicaid is ultimately responsible for the safe and appropriate transfer of residents in a closure situation. So that can be a bit of a challenge in terms of, you know, like take the checklist, for instance. That's been extremely helpful, and it's great to have a good checklist. It's great to have a good closure plan. But if they're not followed and there's not some monitoring that's taking place, then those things have not been helpful in serving the residents. So I think that's a challenge that I see moving forward. And again, I'm hoping that development of some particular products, like maybe a voluntary closure guidance and a flow chart to clearly spell out, you know, the sequence of events for providers will be helpful. I think next we planned on talking about the voluntary closures that have happened during the time that this work group has been operating. So I'll throw it back to Steve.
Prior to the initiation of the work group, there were two voluntary nursing home closures in Michigan that occurred in January and July of 2017 for a total of about 125 residents that were affected. One of the benefits of the checklist is to rapidly accumulate information without having to go back and forth to the nursing home, which can lead, you know, to delays in whatever the eventual process is going to be for closure and the monitoring. So at least with the checklist, the facility knows the required regulatory process that it has to follow, the documents that they have to provide, so that at the same time, that checklist and the documents and the information can also be shared with the residents or their representatives in the facility once the closure plan has been approved, and certainly they would know already because they've had the notices issued to them. So since the initiation of the work group and the checklist, there have been 6 voluntary closures from January up until the present, January 2018 up until the present. And the effect has been on over 500 residents with those voluntary closures. This is the most closures that Michigan has experienced probably in the history of the Medicaid and Medicare program, to at least in recent memory. So the Ombudsman and our colleagues at the Department of Health and Human Services Medicaid office have been quite busy, because they're the ones that are basically doing a lot of the on-site monitoring. Laura, Bureau of Community Health Systems, as the state survey agency, will monitor as needed to ensure that there are adequate services being provided and that there is no harm coming to the residents. And if any of our partner stakeholders or residents or their families believe there is something that is going on that creates harm, they could use our various complaint processes to get information to us, so that we will go out there and do a complaint investigation. So the feedback that we got on the checklist is that it's relatively simple, clear, and easy to follow, and it organizes all the information that the facility has to provide and that we have to review before approval for closure is provided. So having said that, I'm going to turn it back to Laurie and Sally, because they want to get into a little more detail on some events.
Yeah, thank you, Steve. So this is Sally again, and
Sally,
we'll kind of go quickly.
Cynthia, would you try to wrap up in the next 2 minutes, please?
Yep, I was just going to say, we'll go quickly. So one of the first events that we experienced was a facility that had a well documented and detailed plan for resident relocations, very resident focused, and it was a facility that was serving primarily Medicare residents. So it closed very quickly, and residents pretty much just ended their rehab and then returned home to the community. The next event was one where it was part of a larger continuing care retirement community. And so it worked hard to create a very resident-focused plan, and they helped residents relocate either within their CCRC to honor their life contracts that some of the residents had, or they helped them relocate to other settings. So we weren't terribly involved with those two events, other than our local ombudsman was on site to check with residents and to do follow-up. And then I'll let Lori quickly speak about the next few events if she'd like to.
Sure. We then had two facilities within the same corporation that closed. Having two events occur at the same time was a bit of a challenge. The facilities submitted plans that met the requirements for closure, and they gave proper notice. At one of the two facilities, we did hold weekly team relocation meetings, which was extremely helpful. I think the thing that, from a Medicaid perspective, that we found is crucial is that sometimes we can provide technical assistance that can be very helpful. The first round of relocations can be fairly easy for a facility, and they can start to get difficult as they start to encounter a variety of different barriers. You know, one of the things that we can help with from a Medicaid perspective is resolving eligibility issues and things of that nature. And so moving forward, we're trying to help facilities and providers identify those barriers before the relocation start, which can really save some time. Also get them start thinking early about transfer trauma, identifying individuals early on who might be at especially high risk of transfer trauma, and start care planning then for the facility and for the receiving facility as well. The last closure that we had went very quickly. We were excited to see that they had incorporated a lot of the best practice documents into their closure plan. We did participate on site and by conference call. Upon review, though, it didn't appear as if the facility perhaps utilized a lot of their closure plan. So again, we kind of get back to checklists and closure plans are great, but if the actual implementation doesn't include relying upon your closure plan, that's of some concern. Is there anything you wanted to add to that, Sally?
No, the only thing I wanted to quickly add from the Ombudsman program was that we are in the process of developing a fact sheet for when a nursing home closes, and that would be geared towards residents and families. And then we're also looking at creating a guide for our local long-term care ombudsman, just for how they should approach a closure, when they should start, being on site, and the steps that they should take to support residents and families through that process.
Thank you very much, Michigan. Please, anybody who has any questions out there for Michigan or for Tennessee when they present, please type your message now. As you can see, what Lori said and what Sally said is this is an ongoing project. We hope in the next 2 months they'll be able to do the extra resources that Medicaid wants to do, and that Sally will be able to finalize her piece. I'd now like to introduce Tennessee. If we go to the next one, Lori. You can see who our presenters are, and I'm going to turn it over to Jamie.
Thank you so much. My name is Jamie O'Neill, and I am the director of our Choices Long-Term Care Program in Tennessee, as well as over dual eligible initiatives and operations and our nursing facility enforcement. Super excited to get to speak with you guys today. Next slide. Next slide. So, quick overview of Tennessee, just so you know where we stand. So Tennessee, we are TennCare, and we are the state Medicaid agency and Medicaid program. This began as a managed care demonstration in 1994. In 1994, we actually moved our entire Medicaid population into managed care, and it included our individuals with intellectual and developmental disability to be about 1.4 million individuals that we moved to managed care in 1994. We have 3 managed care health plans within Tennessee that operate statewide, and in 2007 we integrated case management to be case management over both physical and behavioral health needs. In 2010 we started our long-term services and supports choices program, and that includes all Medicaid nursing facility services, as well as home and community-based services for our older adults and our adults with physical disabilities. Each individual within the Choices program for home and community-based services, as well as for nursing facility residents, all have an assigned health plan, as well as a care coordinator that's assigned to them. Next slide. So, quick brief history. When we started this process, Tennessee actually had an established nursing facility closure process and had been utilizing this process for several years. And so I want to give you just a high-level quick overview of kind of what we do and just some of the things we do, knowing that in each one of these specific bullets that I speak to, there's tons of work and tons of people that are behind the scenes actually getting these things done. But first and foremost, when Choices began in 2010, it really allowed us to have the capacity to help facilitate this process and make this more of an established process in terms of nursing facility closures. And we actually partner with several state agencies. So with our healthcare facilities, with CMS, our managed care health plans, our AAAD office when we need intake for those who are interested in our home and community-based services that are not Medicaid eligible, as well as our long-term care ombudsman office. This team and this process actually helps us to do a few things. First and foremost is to help us notify and engage our managed care organizations and care coordinators really, really early. Prior to the process, they were not notified until certain different times and different times of throughout the process they were actually communicated with, and sometimes they were either left behind or left out of some information. And so with this process, we're able to notify them the moment that we know, get them in the facility, boots on the ground is what we would call it, making sure that they're talking to their members and making sure they're assisting in terms of helping to facilitate conversations, education around what the options are, as well as what are the potential services outside of the nursing facility should they be interested. One of the other things that we as the state Medicaid agency or the state survey agency does is we do an assessment in terms of capacity for what facilities close to the closing facility has capacity to take some of our residents, just so that we're aware of what that is. And then we also, from TennCare's perspective, provide a written notice to the residents and the family members that includes information around what's going on, what their rights and what their opportunities are in terms of services in another facility, as well as home and community-based services. Also making sure that they understand that it is their choice in terms of where they choose to transition to, whether it be to another facility, as well as if they choose to move into a home and community-based setting. Together as a partnership, we actually host an on-site meeting that is hosted by our state survey agency, and it includes all of the partners that I mentioned before. And we go and we really are able to talk to the residents and facilitate conversations with them, answer questions, help make sure they're connected to their care coordinators. The long-term care ombudsman team is really, really helpful in terms of making sure those who are not assigned to a managed care organization are given the information that they need and help facilitate what process is needed to help them make sure that they're getting their choice in terms of selection of transition. Next slide. We also have what we call daily status calls with the facility, and again, with all of the other participants outside of the AAAD office participate in this call every single day. We have it at the same time every single day throughout the termination process, and we review what we call a daily roster, and that roster includes everything that the facility is wanting to communicate to us in terms of demographic information, plan transitions, when the transition happens, if there's a hospital admission. We talk through any concerns or transitions that didn't occur and why, and together as a partnership or together as a team, we all talk through and work through what is the best next steps for that facility or someone on the call to take as a takeaway so that we can make sure that things continue to move in the right direction. The facility actually submits that daily roster to us every single day throughout the closure process, so 7 days a week, and so even on the weekends that we're able to see that progress is being made, and that if there were residents that were scheduled to transition out over the weekend, that we've got line of sight into that. We also review and on the roster have a place where the facility is able to indicate whether or not the resident has any funds that belong to them and make sure that they are inventorying all of their personal belongings and that those funds and personal belongings are being transferred with them to their place of choice. And this has actually proven to be really, really helpful, particularly with the closing that we're dealing with right now, where the Ombudsman team was able to identify discrepancies in that. And again, having that information on the roster and being able to talk about that on a regular basis is really, really helpful. I mentioned the fact that we talk with our managed care organizations on a regular basis, and so although we don't have them submit a roster every single day, we do make them submit a roster to us about 3 times a week, and depending, we could make that frequency a little bit higher if needed. And what that allows us to do is really reconcile with the roster that the facility is sending to us. So it allows us to be able to determine if the MCOs have the member listed as going to one specific facility, but the closing facility has something else listed. It allows us to reconcile and be able to ask those questions to make sure we have the appropriate information. It also increases the engagement and facilitation of transitions by the care coordination team. It allows the care coordinators as well as our managed care organizations to really be able to help the residents in the closing facility explore their options in terms of transition. And then they also assist with arranging transportation and accommodations to the transition selection of their choice. We've also developed an internal process at TennCare in terms of escalating applications or document submissions to help with eligibility determinations. And so within facility closures, there are times where an individual has either been pending, they've submitted information for their Medicaid application, but they've not heard back, or they have not submitted their application yet. And so our team actually works with our enrollment and review team to make sure that we send escalations over to them on a daily basis and communicate with them on a regular basis to understand where this member is, where our residents are in their application process, what's missing. We make sure we're communicating that back to the facility as well as to the families and our transition team so that we've got our finger on the pulse throughout the whole entire process of what we're needing and who needs to submit what, so that we can help facilitate an eligibility determination pretty quickly. Next slide. And even with all of those steps, like I said, there's tons of different things we all do outside of that or that helps facilitate some of those steps. But there, of course, are always opportunities for improvement. And one of the things that we found to be really, really helpful throughout this process or participating with the Consumer Voice was that we were able to have the Tennessee Department of Mental Health and Substance Abuse join our nursing facility closure team, and their input and participation has been truly invaluable. Just the questions and the feedback and the thoughts that they've had around some of the residents that are transferring has been really, really helpful in the process. we echo Michigan in terms of having a detailed manual process or a detailed written process that's there for those who are coming in new or for those to reference later on down the line is going to be really, really helpful for Tennessee to be able to look back on and to be able to reference. And again, it afforded us the opportunity to really strengthen and enhance our engagement with our long-term care ombudsman team throughout this closure and transition process that Lauren will talk more about. So I'll stop there and just thank you guys for allowing me to share with you guys what we're doing in Tennessee regarding the nursing facility closures and how participation in the Consumer Voice has really helped our process. I'll turn it over to Lauren Meeker, who is our state long-term care ombudsman, and she'll let you know from her side.
Hi, everybody. Thank you, Jamie. The reason that I had originally signed up for this project was when I first came on board, as Jamie has shared with you all, there was this amazing program in place, but there was no protocol in my office of how to interact with TennCare, to interact with our regulatory agency, and what my role was supposed to be and my team. So as I, signed up for this, I learned a ton. And, even if we didn't come away with anything, I've learned a bunch and made some really great contacts. So that's really wonderful. So to start with improved relationships, this has really, really just blown my mind how these relationships have formed. My Memphis team, we're on our third closure right now, and those two ombudsmen I have out there have become more confident. They share more information, and they are out there looking at those residents every single day. So when, for example, someone like Jamie from TennCare or someone from the regulatory agency has a question, the two ombudsmen can usually answer some of those questions because they're seeing these residents every day. And if they can't, they can say, okay, I'm going to go talk to that person first thing in the morning, and I will have your answer on the call the next day. So that has been just the ability for me to expand what the ombudsman role is in the entire project has been, in the entire closure plan has been truly amazing. One of the things, again, in speaking about barriers, our team has faced some struggles with placement for difficult residents, and we've also had, right now we're looking at people we're currently in the middle of a closure right now, and some of those residents, this is their second time being moved because the facility they came from closed, and they're now at this one that is being closed. And so that is presenting a new area for us to work on together to really prevent that relocation stress syndrome. And again, speaking to the relationships, just the fact that we all come from different backgrounds, it's been really good to bounce ideas off of each other to better serve these residents. Outside of and moving forward, just the communications, the fact that I can pick up the phone and call Jamie and know who I'm talking to at TennCare if I have a question about a resident has been invaluable to me and my team, the ombudsman team. I know it's been invaluable to Dennis and his team as well. And just speaking about how this sort of spills over into our regular work, I have an example of we had a gentleman out in East Tennessee that was discharged to a hotel, and the ombudsman were the first people that found out about it. And because of these great relationships that we've formed, I was able to get in touch with our regulatory, and he got in touch with TennCare, and we all got together and wrapped services around this person, and we communicated how everyone was working together and all of the parts. I do this and you do this, and we ended up being able to get this guy somewhere safe. TennCare was able to, save his benefits, and it's wonderful. And I don't know that we would have had that success had we not had this closure team and we didn't already know what each other did. And just another part of that, I've found too, that knowing what everyone's specific roles are. I'm constantly learning. I actually, as Jamie was giving her part, I just learned something new as well. So I'm constantly learning in this, and I think that is really great. Moving forward, so oh, nope, go back, Alicia. Sorry. So we did put together a nursing home closure manual because, again, like I said in the beginning, I didn't know when I came into my role what my responsibilities were. And as Jamie mentioned, it's fantastic to have something for future people who may take over our positions, so they will know what they're getting into. And we are sort of in the end stages of that. We have like the final draft. We're getting ready to get that together. And we're really excited. I really look forward to having that in our hands. And in that manual, it goes over each individual agency and what they do, like a general overview of this is TennCare, this is what they do, this is mental health, the PASSR office, this is what they do, this is what the Ombudsman does, generally, and then it breaks it down more into what each of us do in our roles as a nursing home closure team and sort of areas where we overlap, and it gives us a broad idea of, hey, I now have this question, who do I go to or who do I address it to? And that has really helped us move on. So next slide. Separate from the project that I worked on with the group, I worked on a project alone with the Consumer Voice, and that was to create follow-along assessments to really focus on the relocation stress syndrome and how do we sort of wrap our heads around it, how do we gather data to prevent it. And I created a baseline assessment, which we try to do in the few days, right? As soon as we get the word that a nursing home is closing. The team, in this case, it's recently been Memphis. It would be the Memphis Ombudsman, anyone of the volunteers that want to come out and do it. We hit the ground and we go speak to every single resident in a facility. We go down the roster and we make sure they know that if they know whether or not the facility is closing, we talk to them about where they want to go if they know. We give them a brochure that explains their rights, has a little checklist about what they need to sort of do and to prepare for the closure. But also, and this is something that I did new this time, was print out a list of all of the facilities in the county that had open beds, just so that they definitely were given the choice of where to go. In the baseline assessment, it really goes over general things, what they look like, and that is, it's just a broad overview. Are they clean? Are they, is their hair clean and brushed? Is it not? Are their fingernails clean? Do they need to be cut? Is there an odor about this person? Just a general physical overview. And then we talk to the resident about, what kind of activities they like. Do they get visitors regularly? One of our big questions is, are you a smoker? Because you have quite a few facilities that are going non-smoking. So to know that will certainly help us make sure they don't get placed in a non-smoking facility. And so we gather all this information. I go through it. And I sort of create my own little side roster that has this information. So, and I will share it with the team as needed, but it just kind of helps us know what questions to ask. And the follow-along assessment, one of the things that we were doing when I came on board that I am trying to beef up and make better is the follow-along process. We do, as the Ombudsman program, follow residents for 1 year after a nursing home closure. And that is just the Ombudsman going out and putting eyes on that person once a month for a year. It could be literally a 3-minute conversation, but just to know where they're at and what they're doing. So the follow-along assessment is, I'm going to be changing it because it's not matching my baseline as well as I'd like it to. But the follow-along is going to bring out the things that we find in that baseline assessment. So if we find out, for example, that the resident is a smoker, you know, did they move to an appropriate place where they can smoke? If they really enjoy church activities, does their new facility have really good church activities? If not, that gives the ombudsman a flag to say, hey, I need to go talk to the activities director to make sure this person's getting what they want. So those are, like I mentioned, the areas for growth and improvement. I'm not, like I said, in love with either of my assessments right now, but I am working with the ombudsman that are helping me do them, or I'm talking to the volunteers soon, and I really hope that in the future I will have a fantastic assessment program that I can pass along as a full product to all of the ombudsmen. And that's all I have. So I'm going to pass it on to Dennis Temple, our PASSR director.
Yeah, and as someone who's been involved in the nursing home closure process for well over 21 days, I will give you all my wisdom.
You said days.
Days. Just looks years, but it's really days. One thing I had thought about when I entered into this project was that there would be a dire need for change of status reports to the PASSR department. And that's why I have this slide up there. But as the process has gone on and I've worked with the nursing home closure team, I've found that all I need in terms of clinical information, I can access. So I'm thinking the change of status form and report will be of more use on the back end when we do follow along, and if people need specialized services and they're not getting them. So this slide is just to emphasize, as far as PASSR and additional services, it's there, but I haven't seen the need on the front end. Okay. What I have found is working with people who are out in the nursing home, that would be the ombudsman, and that would even be the staff of the closing facility, is essential to get clinical information, especially about the residents with mental health issues, their present day status. And as I've also found in the second closure that I've worked on, it's important, and I got the information from the nursing facility, it's important to know who's had a PASSR, review that PASSR, and that PASSR was done when these individuals were coming into the nursing facility, and now that they're being relocated, there may be some regression back to their original state because most of them have improved clinically. So that helps you target where issues might be. And the other thing I found is, which surprised me, but then again, I've been at it for 21 days, there are some A&D issues that occur, and some pretty severe A&D issues at nursing facilities. So you probably will be working with, in my case, the other side of your department, finding A&D placement, residential treatment, or day treatment. So that leads into, when you start this project with nursing facilities, as a mental health specialist, I've already seen where it's going to take you in many places, and I will be working with a lot of people in my department, including those in charge of housing and A&D, and probably more that I don't even know about. But I think my biggest takeaway is to work with the folks who actually go out into the nursing facility. In our state, that's the ombudsman, because they have the most up-to-date information. And that pretty much is all I know at this point.
Dennis, thank you very much. I think your work with the Ombudsman and even working with them on that follow-up assessment that Lauren is working on is going to be very valuable for residents. Before I turn it over to Alicia to if we have any time for questions, is just to say that there is going to be some more work on these teams. Both these states are looking towards ways to have some materials for residents and family members. In Tennessee, the manual is for internal for the agencies. And in Michigan, they're also thinking, what can we release to the public, put on websites so that families and residents can also really understand the closure process. This has been a wonderful, wonderful working time with this group, with these groups. It's been a wonderful experience for me to work with them, and it's been wonderful. We have 2 more months to work, and it's been wonderful working with them. I'd like to turn over to Alicia. If you have, we have 1 or 2 minutes. I think we're a little over 3, but if you have time for 1 or 2 questions.
Okay, sure. I thank everyone for staying over time. We got a lot of questions in, so I'll just select 1 or 2. So one advocate asked, what work is done to forecast a potential future closing in order to prepare? So that could be anyone from either team if you want to answer that question, or Cindy.
Repeat that question, Alicia, I'm sorry.
Sure. What work is being done to forecast a potential future closing in order to prepare? So what work does the team do to prepare for a potential future closing?
This is Jamie from Tennessee. I can take that one for Tennessee if you guys want.
Please do.
Sure. So our state survey agency actually does a really great job of sending my team here and the others in our team, in our nursing facility closure team, notification of surveys that have deficiencies identified. And Carol Wilson, who's our assistant director of nursing facility here at TennCare, she actually tracks those for me and for our team in terms of knowing who's potentially in jeopardy of an involuntary closure. And she actually tracks those through the survey process in terms of whether or not they submit an approved and accepted allegation of compliance. And when the survey visit is redone, she's tracking that information and continuing to be in contact with our state survey agency and healthcare facilities to make sure we're aware of what's going on. And we send emails and talk internally of what's potentially going to happen and what's not. But the other thing that we do is once we know, or once we feel like the facility is probably not going to come into compliance, they're not going to be able to meet the requirements that are set forth, or they're not going to be able to pass the upcoming survey, or that their submission is not adequate or is not going to be compliant, we go ahead and notify the MCOs and letting them know that there's a potential closing happening. And what we ask them to do is to not do anything in terms of trying to start moving residents to another facility, but we ask them to first self-identify how many of your members are in that facility, how old they are, what room are they sitting in, and any concerns or any issues that they have been made aware of, to make sure they notify us of that. And the moment that we are notified from the state survey agency, it's when our full process starts. So we're constantly looking throughout survey results and keeping track of that and keeping our finger on the pulse and making sure everyone's at least aware of, hey, where we are with this particular facility. So at any point in time, there's probably a few up in the air that we're concerned about. Majority of them are able to come into compliance and submit the documentation and pass the follow-up survey that's needed. And for those that aren't, we are already aware of them, weeks in advance, if not months in advance, after the state survey agency is able to send us that documentation.
This is Cynthia. Those of you who heard the second webinar or read the report will know that Ohio does something very similar. If there's any facilities in immediate jeopardy, that's sent to the whole relocation team. And actually, some of the team members begin to go into the nursing home, not letting anybody know that a potential closure or decertification is in the works, but begin to get a lay of the land. PASSR people go in and other people, and if the facility comes back into the compliance, fabulous. If not, they're ahead of the game. So please, Jamie, thank you. And those of you who have a chance to look at our full report and our case study of Ohio will see some details about that.
Okay, great. Thank you, Jamie and Cindy, for your insight on that question. So we'll do one more question since we're over time. However, we are going to send the rest of the questions to our state partners and have them review and respond. So thank you very much for submitting a lot of questions. The last question we'll cover is, how does the closing team ensure there is enough staff, and how are staff informed about the closure process? For instance, is there a meeting with the staff like there is one for residents and families, or is it left to the nursing home administration to do?
This is Lauren from Tennessee. I know that when we get to that point, our leader of our team is Vincent Davis. He's the director of the healthcare facilities licensure. Two of the questions he always asks is, have you informed your staff? And one of the things that I do love that he does is he really pushes the facilities to hold a job fair for the staff as they move on. But also we do look at, it is another thing that he does look at to ensure that that minimum level of staffing is there throughout the closure process. And of course, the ombudsman being in there almost daily, the care coordinators coming in and out. If there is a distinct lack of staff, we would know it. So I think we keep them on their toes at that point.
Well, thanks. I want to thank everybody and the participants and everyone who has registered and is listening in. You have the contact information for the people who presented today, and I think they would be very happy if you actually wanted to call and ask or send them an email for information if you need some more help. Thank you all very much, and if you have any questions for Consumer Voice, please send us an email. Thank you.